Amira, before you get going? Okay, Amira, go for it. Hello, Amira. Amira, if you can unmute yourself and we can go. Thank you, Amira, and Claudia and Wasim. Okay, I'm assuming you're all together, so thank you. You can proceed.
Good afternoon. Hi, Prof. Can you hear me?
Yes, thank you.
Hello. Oh, okay. So good afternoon, everyone. So me and my team will be presenting COPD today. So COPD, chronic obstructive pulmonary disease, is a disease characterized by chronic respiratory symptoms and airway obstruction that is due to small airway and parenchymal abnormalities, usually caused by significant exposure to noxious particles. Unlike asthma, COPD is, the airway obstruction in COPD is not completely irreversible. There are two main subtypes in COPD. One, chronic bronchitis, which is defined as a chronic cough with or without sputum production on most days of 3 or more months for 2 or more consecutive years. And two is emphysema, which is a pathological term to describe the permanent dilatation and destruction of airways distal to terminal bronchioles. So this is a slide just comparing the pathogenesis for chronic bronchitis and emphysema. Although there are differences, the main pathological process is the same. So in COPD, the main pathological factor is chronic inflammation, which can be triggered by smoking exposure or any exposure to harmful particles. This then leads to airway obstruction and or destruction, and subsequently a VQ mismatch and clinical features. So if we look at chronic bronchitis, you have these various processes contributing to excessive mucus production, leading to a poorly ventilated lung and good pulmonary circulation. This VQ mismatch results in hypoxia and CO2 retention, which causes cyanosis. As the disease progresses, these patients develop right heart failure and thus become fluid overloaded. Therefore, combining the clinical picture of cyanosis and the fluid retention, these patients are known as blue bloaters. When you're looking at emphysema, the chronic inflammation causes a breakdown of elastin in the alveoli, as well as destruction of the alveoli walls and capillary beds. These changes causes a VQ mismatch, yes, where there is poor ventilation due to loss of elastic recoil of the alveoli, causing air trapping, and poor circulation due to the damage of pulmonary capillaries. Patients with emphysema usually develop cyanosis later in the disease, and due to the alveoli wall damage, they have pursed lip breathing. This is a way that these patients apply positive expiratory end pressure to prevent airway collapse during exhalation. So with the lack of cyanosis, i.e. the pink appearance, and the pursed lip breathing, these patients are known as the pink puffers. So if you are in a clinic and you have a patient who you suspect might have COPD, these are the few important things to look for in the history. So here are the symptoms that the patient might present with. They include dyspnea, cough with or without sputum, tight chest, or wheeze. The most important part of the history taken is the history of inhalation exposure, mainly cigarette smoking. It is important to also calculate the pack year history in patients who smoke, as the risk of developing COPD increases with the number of pack years. Other exposures also include occupational exposure and air pollution. So there are various screening tools available on the internet that can be used to help identify patients with COPD. This is the CAPTCHA questionnaire. It's a screening tool that is used in the USA. As far as I know, South Africa doesn't have such screening tool, but I think if we can identify the main risk factor, which is inhalation exposure, most commonly cigarette smoking, then we can look for other features of COPD in these patients. So these are some of the features that you might find during examination. So there'll be low saturation. Patients can have cyanosis, but which is more commonly in patients with chronic bronchitis. They can have pursed lip breathing, which is most common in emphysema. There can be nicotinic staining of fingers, signs of respiratory distress. So the most important finding in COPD is signs of hyperinflation. These signs include barrel chest shape, which is most common in emphysema, decreased chest expansion, increased resonance on percussion, and decreased liver and cardiac dullness. On auscultation, you can also hear low-pitched wheezes and early inspiratory crackles. And as the disease progresses, patients can develop right heart failure, and then you can also find signs of right heart failure. So based on the clinical features that you find in patients, here are the investigations that can be done in these patients. So you can do a chest X-ray. You can look on the chest X-ray. You can look for features of COPD, and you can also exclude other diagnoses and comorbidities. Then you also have peak expiratory flow rate, which is usually used in clinics to assess if patients are controlled on treatment. Here's just a diagram just demonstrating how patients, how they measure the peak expiratory flow rate in clinics. And then finally, there is spirometry. So spirometry isn't really available in clinics, but it's used to diagnose COPD.
Okay, so the next part we're going to be focusing on is the diagnosis. So it's usually made in line with the symptoms that the patient presents with and a history of exposure to the triggers as mentioned above. We must also be aware of the contributory factors such as asthma, workplace exposures, indoor use of biomass fuels such as paraffin, and the history of TB, which is quite predominant in our country. And then also sometimes patients can also be screened for alpha-1 antitrypsin deficiency. It's not done often, but it can be found in up to 5% of patients with COPD. It's quite a common genetic condition, leaving patients predisposed to developing chronic lung disease and liver disease. And then the confirmation of COPD usually done by spirometry. So there's the airflow limitation. So the forced expiratory volume over 1 second over vital capacity, the ratio would be less than 0.7, and it's not completely reversible after the administration. Also, a part of the diagnosis, you have to also look for other diseases that might cause similar symptoms. So your chronic obstructive asthma also present this in similar manners, and you have to note that asthma and COPD can coexist in the same patient. And as well as chronic bronchitis. However, these patients may have normal spirometry. Central airflow obstruction, so an example would be a cancer, bronchiectasis. So these patients also present with cough and sputum production, and you can usually diagnose with CT scans where you'll see the bronchial wall thickening and luminal dilatation. Heart failure also presents with similar features, and that's all you differentiate this with on examination, such as basal crackles on auscultation. Your X-ray changes of heart failure, such as enlarged heart, and then increased proBNP, which is a blood test. TB, as well as conjunctive bronchiolitis and diffuse bronchiolitis, which is less common. So in terms of staging the disease, we use the GOLD ABCD evaluation. So it combines 3 factors. So the first one would be your severity of your disease, which is expressed as the FEV1. The second part is symptoms. So breathlessness is assessed. So that's using the Modified Medical Research Council breathlessness scale, and as well as the COPD assessment test. And then third, you would also consider the history of exacerbations. So that's an example of how all of these are combined in order to give, to classify the patients into the GOLD classification. And then, so for group A, these patients will be minimally symptomatic. They have low risk of future exacerbations. The MMRC is 0 to 1 with a CAT score of less than 10. They have 0 to no exacerbations and no history of exacerbations. B would be similar to A, except they are more symptomatic, and the MMRC grade is more than 2 with a CAT score more than 10. C they are minimal symptoms, however, they have an increased risk of exacerbations per year, and they may have had a previous hospitalization. And D is your more symptomatic patients with history of exacerbation or previous hospitalization. And now we're going on to management.
So the management of COPD is divided into 2 parts, namely stable and acute exacerbations of COPD. It is important to keep in mind that patients with COPD are likely to be older with multiple comorbids such as obesity, OSA, or heart failure. They may also be taking opioids for pain management, and all this needs to be taken into account in managing a patient, and treatment should be directed accordingly. All patients with COPD should be encouraged to do the following at each visit. Risk factor modification, which is a reduction and eventual cessation of smoking cigarettes or other recreational drugs. Pneumococcal and influenza vaccination should also be encouraged. I'm not sure about this in the public sector, whether or not they provide or at any facility, but if the patient can afford it, then it should be done in private. Chest physio and exercise is also to be encouraged, and correct inhaler technique should be reviewed at each visit. Importantly, patients should be counseled on the strict avoidance of COVID exposure, as it is associated with a greater likelihood of ICU admission, invasive ventilation, and death. The aim of therapy for stable patients is to improve symptoms, decrease exacerbations, and improve patient function and quality of life. So based on the GOLD classification, specific bronchodilators are recommended for stable patients. GOLD A patients are minimally symptomatic and have a low risk of exacerbation and should receive a short-acting bronchodilator for acute dyspnea relief. This can either be a short-acting muscarinic agonist, a SAMA, such as salbutamol, or a short-acting beta agonist, a SABA, such as ipratropium bromide, both of which are available on the EML. Short-acting bronchodilators have a rapid onset of action. However, the duration of action is limited to 4 to 6 hours. Both SAMAs and SABAs can either be used alone or in combination. GOLD B patients are more symptomatic but have a low risk of exacerbation. These patients should receive a long-acting bronchodilator in conjunction with a short-acting bronchodilator for acute dyspnea relief. These are either long-acting beta agonists, LABAs, salmeterol, or indacaterol. Indacaterol is also known as Ombres and can be prescribed with consultant permission at the tertiary level. However, as far as I know, it's not available in the primary sector, health sector. Otherwise, a long-acting muscarinic antagonist, LAMA, either tiotropium or glycopyrrolium can be used, however, neither on the EML. The choice of long-acting bronchodilator is based on the patient preference and side effect profile. LABAs can cause a resting tremor and tachycardia, and LAMAs can cause a urinary retention. Thus, patient comorbids should be taken into account when deciding to prescribe either of these. LAMAs are more effective at reducing exacerbation than LABAs. However, there is no difference between the two when it comes to improving shortness of breath or quality of life. Gold C patients are minimally symptomatic but have a high risk of exacerbation, and it is suggested that a LAMA be exacerbations. Gold D patients are more symptomatic and have a high risk of exacerbation. For these patients, a LABA-LAMA combination is preferred over a LABA inhaled corticosteroid regimen. However, if you are going to add an inhaled corticosteroid, it is better at reducing mortality and exacerbations than just the bronchodilator alone. In terms of non-pharmacological therapy, this would mainly happen at the tertiary or quaternary sector, where you would provide supplemental oxygen for home use for the chronic hypoxemics. CPAPs are, as I'm aware, not available in the public sector, but it's something for private. And then surgical procedures can be considered at the tertiary and quaternary sector. But again, that's for specialist decision-making. In terms of monitoring, COPD patients should be seen 3 to 6 monthly at the clinic. The oxygen saturation, smoking status, and adherence to medication should be assessed. They should also be asked about their shortness of breath, and it can be tracked using the MMRC scoring system. On to exacerbations. The WHO defines an exacerbation of COPD as an acute event characterized by a worsening of the patient's respiratory symptoms that is beyond the normal day-to-day variations and leads to a change in medication. This includes an acute change in one or more of the following symptoms. Cough increases in frequency and severity, sputum production increases in volume and or character, or dyspnea increases. Some of the symptoms that can be reported when a patient is experiencing an exacerbation include a wheeze, chest tightness, shortness of breath, or increased cough. Next, you have to, when you see a patient, you should decide if the patient needs to be managed at home or in casualty. This will be based on the clinical severity and whether or not the patient is in respiratory failure. Clinically, one can assess the severity as either moderate or severe. An easy way to remember would be to assess them from head to toe. Moderate patients would be agitated, whereas severe patients would be drowsy or confused. A moderate patient speaks in phrases, whereas a severe patient speaks in words. A good clinical tool is to ask a moderate patient to count from 1 and get to the highest number they can using one breath. Later, after management is initiated, you can ask the patient to repeat the same exercise to gauge a clinical response to treatment. In terms of the vital signs, a moderate patient has a pulse rate of between 100 and 120 beats per minute, and a severe patient has a tachycardia of more than 120 beats per minute. The respiratory rate of a moderate patient is 20 to 30 breaths per minute, whereas a severe patient has a respiratory rate of more than 30 breaths per minute. Lastly, on auscultation, a moderate patient has a loud wheeze, whereas a severe patient may have a loud or absent wheeze. The respiratory status of a patient is divided into whether or not there is failure, there's no respiratory failure, non-life-threatening failure, or failure of a life-threatening, or life-threatening respiratory failure. Parameters to look at include respiratory rate, oxygen saturation, mental status, and hypercapnia. Patients who decide to manage as outpatients should be stabilized and discharged with a stepped-up bronchodilator regimen. They should also be discharged on oral glucocorticosteroids such as prednisone for 7 days and may need an antibiotic. An antibiotic can be prescribed if 2 out of 3 of the following are present: increased shortness of breath from baseline, increased sputum volume, or increased sputum prevalence. Stabilizing an exacerbation involves administering bronchodilator, either via MDI or via nebulization. 4 to 8 puffs of salbutamol MDI can be given with a spacer allowing 4 breaths between. This is repeated every 20 to 30 minutes for the first hour, therefore thereafter every 2 to 4 hours if needed. Or a salbutamol 0.5% nebulized solution can be given, repeated as above if needed. An adequate response is an improved PEFR of more than 20% from baseline, a respiratory rate of less than 20 breaths per minute, and normal speech. Based on GOLD guideline, patients can be referred to the hospital if there's an inadequate response to outpatient or emergency department management, new onset of signs, i.e. cyanosis, altered mental status, or peripheral edema, marked increase in intensity of symptoms over the baseline, such as new onset resting dyspnea, accompanied by increased oxygen requirement or signs of respiratory distress, a history of frequent exacerbations prior to hospitalization for exacerbations, or serious comorbids, including pneumonia, cardiac arrhythmia, heart failure, diabetes, renal failure, or liver failure. According to the national guideline, all patients with a severe attack, according to the clinical severity, should be referred. Poor response to casualty management, a PEFR of less than 75% predicted, presented in the afternoon or late evening, recent onset nocturnal symptoms, or previous severe attacks, especially with rapid onset. While awaiting referral or EMS, patients should be given oxygen bronchodilator therapy as well, and sets to be maintained between 88 and 92%, so as to prevent worsening hypoxaemia. Maintaining these stats are associated with a lower mortality.
Wasim, your sound is challenged. I'm not sure your connection is challenged.
Therapy should be initiated as well. Oral, or hydrocortisone 100 milligrams IVI via slow infusion. Ipratropium bromide nebulized can also be used.
We're going to stop there. It seems like their connection's challenged, but I think they came to the end of the time, and we have also got not enough time for any questions. So I'm going to just share with you a few thoughts. One is that the guidelines, the national guidelines, South Africa, which is the PHC treatment, standard treatment guidelines, does allow you to use in primary health care does allow you to use LABAs. So you can use LABAs in a combination with corticosteroids if a patient is not controlled on SABAs, the short-acting. And even if you don't have a spirometer available, you can in fact progress to do that. So please, if you are in a primary care context, do ask where are these drugs, because they should be available to you, and it's not expected to be managed by a specialist. So it's any primary care doctor could do that. So please make sure that you give patients what they deserve by virtue of the guidelines. I think thank you for the presentation. It was very useful. One thing that's important that we must remember, I think the kind of information that's being provided, you've got to translate it into what is useful for you and really in primary care. So don't just simply provide either too little or too much in the way of information, but reflect on how am I going to use this information? What information do I share that's useful in primary health care? And some of the guideline that's been presented, that some of the information presented speaks importantly to the emergency context, and I think that's fine. But many a time in primary care, the patient that we're going to see with COPD will present as this guy with a chronic bronchitis coming here regularly. Sometimes people don't even notice it by looking at the charts to see that this is not an infrequent occurrence 2-3 times a year that this person's coming in with a bronchitis. He might say that's just a bad flu. And of course, if you do the history taking, which is picking up the smoking, most times that's the sort of trigger, and you need to be aware of that. So beware, and this may progress with repeated treatment where you just ignore this and don't warn the person, and then it just progresses to COPD with the various projections that have been shown with either emphysema or COPD. But basically, you're looking at the two combinations. So in terms of your presentation, please provide us the reference in the slide, not at the end. In the slide, when you are talking about various things, and try to think of the evidence base behind it. Like I was just looking quickly to see what is the evidence around the alpha-1 antitrypsin deficiency, and it's not very strong. I'm not very clear about it. But if you see something you want to suggest, please use a reference, tell us why, where you got it from, and think about how you are actually backing your information provided. So thank you all very much. I think this is great. I'll trust that I have seen that both the presentations have provided us cases. So next week, we will provide you those cases, and